Good morning. I'm Bill Barrett from Seattle, and Jay, great talk. We're going to transition from highly supported journal club, and Jay, as usual, giving a talk that is just replete with documentation, and we're going to enter sort of a data light zone of robotics in total knees. And to start this journey, Nader's going to talk to us about getting started with robotics, practical tips, training, things like that. So we're going to go first with that. Keith's going to then talk about doing it in a surgery center, and then we're going to finish up this session with Stefano talking about his journey, alignment, and robotics. So that's the order of play.
Okie dokie. Thanks, everybody. Derek and Jeff, thanks again for inviting me. This is always a great weekend for me, and Aaron for all the hard work to wrangle all the cats and make sure that we're supposed to be where we are. So I've been tasked with leading off today, so it's a little bit of a tough pull, especially after the journal club. So my job today is going to be pretty much to level set and talk about robotics in general, and then at the end sort of talk about my learning opportunity and my learning curve. These are my disclosures of importance as I do consult with one of the companies regarding technology. And this will be my roadmap today. So we'll talk about why robotics and does it make sense today, and how. What I will not touch on today is the cost or the economic impact of it. I think that's something that's certainly worth a discussion, and maybe we can touch on it in the session afterwards, but I think it's going to be certainly a topic of discussion. The what is going to be from Stefano, and then the when and where I'll let Keith take care of. I think that in our journal club, this sort of reared its head, and that's talking about biases in terms of technology in general. So there's certainly a lot of trepidation when you think about adopting to new technologies, whether it's discomfort with lack of control, predictability, or negative biases that we might have. And so what I ask us as we talk about this today is let's suspend those biases and talk truly about what it's going to take for us to evolve our practice and evolve our industry over the course of the next decade or so. And why? Well, we all know the 20% dissatisfaction rate of patients with their total knee replacements. We sort of have this bell curve and have not been able to skew the outcomes over the course of not just years, but decades. And there's been consistent year over year, and with a lot of data from registry data across the country and across the world. And this is in spite of having improvements in our instrumentation. We've gotten better at hitting our target with mechanical alignment, navigation, cementation technique, and even cementless fixation. And we've even improved our designs of our implants that our kinematics have improved over time. In addition, if you look at our more recent AJRR data, although infection and mechanical aseptic loosening tend to be the highest reasons for revisions, there's still about a third of our patients who are experiencing or stability-related revisions, whether it's nondescript pain, mechanical complications, or other instability episodes. So this is probably has been in every knee talk that we've had since the inception of knees. So this idea of a balanced flexion and extension gap that's rectangular, this is our gilded Bible, and this is what we've been living with for a long time. But recently, we have really come to the idea, well, maybe there's more to this than that. Maybe we need to think about knees differently. Maybe not every knee is the same. And although it's very easy by the eye to see a rectangular space, it's very hard for us to understand, well, how trapezoidal can we make it and the patient be okay? And does every patient have to have the same geometry as another patient? And you can see multiple studies, and I'll defer to Steph for this part of the talk, that we might start thinking about this differently. And so, in general, our goals of a knee replacement is to restore alignment, to balance the ligament, and to maintain a good patellofemoral articulation. And so we've talked about mechanical alignment, and then there's these new concepts of restricted, inverse, and standard kinematic alignment. And as part of that thought process, our instrumentation has improved. So we've developed these tensioning devices. We have developed use of our navigation systems, and those are probably 2D navigation systems, tools to give us the ability to change the varus valgus deformity or flexion of our femoral component. And then with the evolution of robotics, well, that gives us a little bit of a more granular control of our implants, a little better positioning to the sense that we can do it in a way that our eyes can't even see. So when we talk about robots, there's multiple factors that are associated with it. There's the cost of it, how long it takes to set up, and adoption by not just the surgeon, but by the clinical staff. How much space does it take in our operating room, whether it's CT or imageless, and that certainly is problematic when you're talking about pre-approval for certain patients to get a CT scan, and ultimately how it's used, whether it's a block or a saw or a burr. And to talk about the advantages of robotics, so there's certain advantages that we know are true, and there's certain advantages that we don't know are true yet. So from a surgical standpoint, we know that it improves precision and alignment of the knee. So that has been shown multiple times, and I'll go through that data a little bit. But in addition, it makes us not cheat. We can't cheat ourselves. We can evaluate objectively the kinematics of the knee before the reconstruction and then after the reconstruction, and potentially plan the operation intraoperatively before we make our first cut. Clinically, questionable, right? So improved clinical outcomes, improved survival, we're not sure there yet. And economically, you can certainly have an increased economic cost of having the implants and the cost of the capital cost and the disposables. But what's the upside? Can we reduce the tray use? Can we reduce revisions in the future? How about patient demand and the demand that patients have on us with consumerism? Although that should not be a priority, certainly patients are starting to ask about this more and more. Disadvantages, obviously learning curve and time associated with it, and for some, reaching time neutral is very difficult. The footprint, especially in an ASC, may be a challenge. Capital costs and disposables should not be ignored. And then pin-site comorbidities, although are not significant, are present and are non-zero. And this is not a set it and forget it, Ron Popeil kind of situation. So robotics, certainly better accuracy. Multiple studies have shown that robotics can produce a more aligned, or a knee that's better aligned to the target than traditional instrumentation. However, does that result in better clinical outcome? The answer is not really. So again, multiple studies have shown that, and in a more recent randomized study and meta-analysis, it really does show that there's no clinically important difference comparing robotic and conventional total knees, and it's still inconclusive in terms of revision and complication rates. But that really should not be surprising, because we are still aiming for the same goals. So we should not predict a different outcome if we're looking for the same goals, which is mechanical alignment in this situation. And to Eric's point, the data for level 1 data is not very strong yet. It's developing, and I think we're going to see more and more data come up in future years. So what do we need to know today? Well, robotics are comparable in safety. They are similar in short-term outcomes. They do provide better accuracy in implant position, and they do have increased cost and potentially increase in time. What we can answer today, however, is that we don't know what the ultimate midterm and long-term outcome is. I think survival advantage is still a question. And we don't know, based on the use of these new technologies, whether we're going to be able to make a change in our TKA albatross 20% unsatisfied. And part of it could be a supratentorial problem. So we might have to have a psychiatrist as part of our group. And then finally, and this is a question that's going to evolve with time, is our technology there yet? So I used this this slide last year, but I think the future of robotics is still to be determined. Right now, we're still in the infancy of robotics, and I'd say we're in first and second generation robots. Part of this is a feedback loop that's associated with the data that we're gathering, and that goes from a descriptive analytics and being able to do what we're told to having a situation where we have a prescriptive analytics where we have decision support to get us to the point where this patient requires this knee alignment form. And I think that's the goal that we'll have in the future, and that comes with AI integration. And I think that's going to be the future of robotics and in general of technology that's integrated into the orthopedic practice. This is a flourishing field, especially with now ChatGPT being something that is in everybody's browser history. And I think it's going to be interesting to see how this develops over the next several years. So why did I integrate robotics in my practice? So several reasons. First and foremost, I want to maintain patient safety. So the data is equivalent. So there's no there's no penalty to this except for maybe time and money. And it's not something I do on every patient. So I'd say probably 15% of my practice is robotics. I think we have to understand that with a total knee kinematics and our understanding of total knee replacements is changing, you have to be able to anticipate new technologies that might be able to help you manage that shift in understanding. Working with technology now is going to help you predict what's going to happen in the future and being able to be an adopter in the future. So usually the saying goes, don't be the first one to adopt technology, but also don't be the last one to adopt technology. So being sort of in the middle of the road, I think it's safe. And then finally, from my standpoint, my practice, I think fellow education becomes important for these, and I'll talk about that in a little bit. So lessons learned here. So there's a lot of growing pains when you start with the robotics. So first of all is how do you get your team and on your OR setup? So there's a lot of things that you have to keep in mind, and part of it is just getting the practice. So line of sight, where's your camera? So typically I rotate it a little bit more superiorly. I get my tubes and wires out of the way. Assistants become a little bit of a problem because you're doing a little bit of a dance to be able to get your assistants out of the way while you're trying to get the registration and make sure the camera sees your optical trackers. And the footprint of the robot, so depending on what robot you use, is going to determine what kind of room or what kind of setup you'll need. Going into the knee, as I have adopted the technology, I had to change my technique a little bit. So where do you put your arrays? I personally put my arrays all inside the wound. I don't like to have extra incisions outside the wound, and personally, this has not increased the length of my incision too substantially. Optical array position has also a big learning opportunity, and that's part of the learning curve, how you set them up and make sure that the camera sees them throughout. Part of the challenge of it, again, is the setup of your assistants and your retractors. So retractors tend to change a little bit, especially using self-retaining retractors, so your assistant does not need to be there. You have to be careful as well, because if you're doing this and their assistant's not there, there's a potential for injury, either your patellar tendon or your medial collateral ligament, so you have to be very comfortable with your knee retractor positioning. And I do a lot of things more up front. I do a lot more osteophyte removal. My soft tissue release on the medial side, especially in the varus knees, much bigger, especially that want to correct. And then I do my patellar resection first just to make my exposure easier, and sublux the tibia, especially if you're going to go with a tibia first workflow. The biggest challenge people have will be managing that data overflow. So this is something that if you're starting with manual instrumentation, you're overwhelmed at first. So it just takes a little bit of practice. But just because you're looking at that screen, it doesn't mean you have to ignore your fundamentals. Just make sure you understand your knee very well. And at the same time, you have to trust but verify. Does this data make sense? Am I going to be working off of something that's going to lead me down the wrong path? So you have to have some healthy skepticism whenever you're evaluating your knee with robotics. And interpreting the data does take a little bit of practice. So my advice is make sure you evaluate your knee before you look at the screen. So is the knee loose or tight? Does the knee correct or not correct? Before you look at the screen at all to see where things are. In the system I use, we do get a little bit of tightness as we go into terminal extension. That's because of the posterior capsule, which causes this somewhat of a J curve that increases your tightness in extension. So you have to be careful of that. And just be aware, just like a manual knee, your knee will get looser as you perform the procedure over time. So mind that as you're moving forward. With my workflow, I don't chase numbers. This is still a bony and soft tissue operation. So you have to plan for your soft tissue procedure just like you would in a traditional knee. I make my plans from the get-go. I have a femur first workflow, and I plan my entire procedure before I make my first cut. And then you still have to evaluate your extension and flexion gaps just like you would traditional instrumentation. So a typical thing for me, I'll look at my gaps. Are my gaps too tight? I'll adjust my tibia. And then I'll look at my extension gap, can adjust my distal femoral and proximal tibial cut, potentially work on the alignment of our tibial and femoral varus valgus angles. Then I'll look at my flexion gap. And I think for me, this is where most of the power is. How can I adjust the flexion gap to give me what I need? And that's the 3D model, right? I can flex the knee. I can rotate the knee in any way I want. And then finally, does it make sense? Am I within normal reasonable limits for me? So, and for some people, they have higher tolerance than I would in terms of their overall mechanical alignment. So this is not intended to show that, oh, this is great. This is an easy knee, but you can go from before and after. And finally, you can verify, make sure that you did the right thing with your balance graph. The learning curve. Certainly the learning curve is a frustration for surgeons as they adopt this technology. So every robotic system is unique, but they all have common elements. How you set up the room, the optical trackers, your assistants, the retractors. And there's going to be ups and downs that are associated with it. Learning curve, there's multiple studies that have been done, is about 20. 20 cases will get you to a point where you're very comfortable with the instruments and you have sort of plateaued in your efficiency. That changes. Some studies have shown that up to 60 cases takes that. And then when it comes to time neutralities, there are some studies that show you don't get to time neutrality, some show 10 minutes, and some show you're able to get time to time neutral. And I think it's very surgeon dependent. And obviously, you have to walk before you can run. You have to look at first mildly correctable deformities, moderate fixed deformities, post-traumatic, and then finally severe deformities with restricted range of motion arthrofibrosis. But don't challenge yourself too much right away because there's a lot of learning that's involved in this process as you're adopting this new technology. When it comes to training, however, this is something we have as surgeons and educators have to be very careful of because this potentially can backfire in the future. So with a recent survey, 20%, 1/5 of the senior residents had more than half of their experience be completely robotic. Of those, of all the residents, half said that helped them with understanding their knee replacement surgery better than not using it. And 25% felt that it negatively impacted their ability to do their knee replacements. And overall, residents did not impact the surgical time when it came to robotic. So what happens when they go to fellowship? So we have seen over probably the last 2 or 3 years, a large variation of experiences with manual and robotic instrumentation before starting fellowship. And fellows now are starting to ask about it in actually one of 2 ways. For some fellows, they do not want the robotic experience. They want to learn how to do a manual knee, while others do want the robotic experience. But I think our primary goal as educators is to teach fellows how to do a well-balanced knee without the robot, because if they can understand that, they can get themselves out of trouble afterwards. But the upside is that robotics can be a great teaching tool. We can visualize the knee balance graph. You can improve the ability of the fellow to understand how to manipulate traditional instrumentation to be able to achieve this goal. And it gets the fellow through the learning curve faster when you're working with somebody who has been through the learning curve before. But again, robotics are not a substitute for being able to do a manual knee, because my concern is that in the future, we're going to have a lot of badly placed knees because people trust the robot too much. So what are my takeaway points? First, robotics are no longer a fad. They are becoming part of our normal armamentarium. As we get more data in terms of kinematics and the different alignment strategies, they're going to be more part of our repertoire. They are safe and efficacious, at least in the short term. We have to be patient and go through the learning curve, and we cannot turn off our brain. We still have to be the surgeons that we are without the use of these tools. And although the fellows are learning this, they have to be proficient in their manual instrumentation as well. And then at that point, I will stop and pass it on to Keith.
Good job, Mayor. Thanks.
All right, if we can bring up my slides. First and foremost, I just want to thank Jeff and Derek for allowing me to come to this meeting and talk with you all today. It's been wonderful being out here in California. And I also appreciate the ode to Ricky Bobby with the title, being that North Carolina is the home of NASCAR. But we're going to talk a little bit about efficient knees in the ambulatory surgery setting. These are my disclosures. The only one that's pertinent is I am financially invested in ASC. So today we're going to talk about outpatient total knee arthroplasty in the ASC and how we can be safe, efficient, have a less costly site of care, allow for more surgeon control, and hopefully this leads to high patient satisfaction. So how did we get here? Probably the biggest driver of all of this is physician ownership in ASCs. That, coupled with shared savings programs, rising insurance costs, has driven these cases out of the hospital. And the bottom line is your hospital has become too costly as a site of care for total knee arthroplasty in 2023. So now more than ever, we have a place at the table at the ASC, more so than the hospital. We're involved in these conversations on a daily or weekly basis, looking to take back control the costs, control the pathways, and hopefully eventually control patient outcome. So in 2020, our world changed forever, and with the COVID-19 pandemic, and outpatient surgery was no different. These cases were driven out of the hospital into the ambulatory surgery setting and showed us that we could do these surgeries effectively and safely. And frankly, the patients don't want to go to the hospital anymore. It's a patient preference thing, and they just want us to send them home after surgery. But like many of you all had concerns, I wondered, is this a safe option for our patients? This is a systematic review, an older study looking at 19 studies that showed highly variable patient selection practices as well as variable complication rates and readmission rates with these studies. This is a more current article out of the Cleveland Clinic looking at Nassif database, looking at outpatient versus inpatient procedures, both total knees and total hips. And the results showed lower rates of adverse events in these patients and no difference in readmission rates at 30 days. This is another article looking at very same topic at Anderson Clinic, looking at outpatient total knee arthroplasty in the ASC and the hospital, showing no difference in readmission rates, reoperations, and emergency room visits. There's an actual article looking at total hips. I know we're talking about total knees, but the theme is the same. No difference in readmissions, reoperations, and triage phone calls to your clinics. However, they had a 24% failure to launch, failure to discharge rate in this study, most likely due to pain, patient preference, and urinary retention. And I kind of say that the narrative has to come from the staff. If one physical therapist or one PACU nurse tells the patient in the hospital, you might be better off staying the night in the hospital, that's going to put doubt in their mind and have them go that direction. So in 2023, I think we've established that outpatient total knee arthroplasty is safe, but how can we be effective with it? And how do we increase that success rate? And that starts with us in the exam room. You don't just wake up one day and start doing same-day surgeries in a surgery center. You need to establish same-day discharge protocols. You need to educate yourself and your staff on what are the common failure mechanisms in these patients. And like I said, the narrative starts with us in the exam room. It starts in the clinic, and this needs to be the same narrative all the way along into the PACU and ultimately discharge home. So do you do these in the ASC or the hospital? The hospital is a good place to start. That's where I started. You need to understand your failure rate will be higher in this setting, but it's a good place to kind of dip your foot in the water. And then once you're comfortable, you can move to the ASC setting. So you need to prepare your patient, practice in the hospital, and set yourself up for success in the ASC setting. Like I said, it starts with us in the exam room. We need to be changing the narrative. In 2019, I was telling patients, we can do your surgery in the surgery center if you want. Some people want to do that, some people didn't. But in 2023, I've changed that conversation with the patient and basically telling them these are outpatient surgeries that we do in the surgery center nowadays. And then we go through the criteria checklist, make sure there's no red flags that don't allow them to go to the ASC. So from your standpoint, you want to keep your surgery the same, just a different venue. You want to standardize your protocols, bring the patients to the ambulatory center, surgery center. With administrators, they're going to be open to this change. They want it to be successful. They want to know what protocols have worked, what hasn't worked. And everything around your surgery needs to become more efficient while keeping your surgery the same. So when you move from the hospital to ASC, you want to avoid change. Obviously, you're going to have the same surgeons, same anesthesia protocols if you can, same OR staff if you can, same equipment, and same implants. Try to decrease the variables when you're making this big change in your practice. The number one factor in efficiency in the OR is going to be consistent teams. Most of you are probably running 2 rooms in a high volume joint replacement practice. These people are going to know your steps. total knee has around 100 steps. If you're wasting 5 to 10 seconds asking for instruments, that equates to a lot of minutes over time. There's only so much faster you're going to get in the operation, but your team around you can help you be more efficient. So turnover time is something we looked at. How is it measured? Traditionally, this has been measured wheels out to wheels in. We kind of tried to change the narrative in this aspect as well, looking at wound close to the next skin incision on the next patient in that room. What about patient satisfaction? Both of these groups, inpatient and outpatient total knee arthroplasty, have shown very high patient satisfaction, but this is a study out of Rush looking at patients at the outpatient surgery center had slightly higher satisfaction rates. So the time is now for outpatient total knee arthroplasty in the ASC. I'm going to go over a little bit about how we do that in Charlotte. So all of our patients that are ASC candidates get a standard workup evaluated by their, usually their primary care doctor, and this is reviewed by the anesthesia team for any red flags that may require further workup, and they will actually help initiate and organize that workup. We have kind of some broad criteria. Obviously, you want these patients to be healthy, no significant cardiac or pulmonary issues. At one point in time, we didn't allow any sleep apnea. Nowadays, we do allow it with adequate CPAP use. BMI under 40 and good family support at home, which can't be overstated. It's important from a social standpoint that these patients are ready to go home after surgery and everybody's on board with a same-day surgery, including their family members. These are kind of some busy slides that show sort of our broad criteria. The ones that come into play most are usually BMI as well as cardiac and pulmonary conditions. These are some of the kind of more minor criteria, but do come into play on occasion. We have a surgical optimization program in Ortho Carolina that involves hemoglobin A1C monitoring, BMI under 40, as well as nicotine-free for 30 days in order to have any surgery. So these are the same requirements we've adopted at the ASC, so it makes bringing these patients to ASC easier. And your personal comfort level with taking patients to an ASC is going to be different. It's going to vary surgeon to surgeon. Personally, I don't want the patients to have any major heart or lung issues. Under 75 years old, put an asterisk next to that because next week we have somebody that's 82 that we're going to do at the ASC because she's insisted that she will not go to the hospital and only wants to be done in an outpatient setting and did that years earlier. Obstructive sleep apnea with good CPAP use, no chronic narcotic use. And I kind of put this in there. They want them, or I want them to be straightforward orthopedically. I don't want to have some complex primary joint replacement that I'm doing in an ASC setting. As far as pain modalities, we use a multimodal pain protocol. We use intra-articular injection, which is probably very similar to what most of you use in practice. And this has been very effective in the outpatient setting for getting the patients home. In the PACU nurses immediately get the close on the patient, gives them kind of the mindset that they're going to be passing physical therapy and then going home. We want to make sure their pain is adequately controlled, and then also any anti-nausea medicines on board, and finally completing all the tasks of physical therapy. So we touched on it a little bit, but what about robotics in the ASC? I do use robotics in our ASC. This can be efficient, can be time neutral, and it can be cost neutral in the long run. So I think it's important when you're bringing robotics into your practice at the ASC that you need to be independent with your robotic platform. You need to know how to run everything yourself. You shouldn't be reliant on the rep to run the screen. And I'm pretty adamant about this, even when I show it to our fellows, is that I want to be the one to control the monitor as well as the foot pedal when taking certain points. This allows me to kind of know what I'm thinking. I don't have to tell the rep and then see what they do to change the degree or the resection level. And so it's important that you're independent in this process, and it's going to lead to efficiency in robotics. Nader touched on this earlier, but it's important to kind of do the dance with your assistant. All these different robotic systems have certain sight lines that you can't block, and oftentimes an assistant can be in the way in this, and so you kind of need to get your routine down with your assistant in order to not block these arrays and be a little more self-sufficient. As you can see here, I'm holding retractors while running the robot, and have your assistant only assist when necessary. So why robotics in the ASC? For me, it allows to eliminate outliers, allows for precision, and an ability to dial in your balance and possibly end up in less soft tissue releases. And I touched on it a little bit, but this is going to help us move towards cementless total knee fixation, as we talked about earlier. Most of these platforms nowadays have simple, efficient registration, as well as the planning process. Some other surgeon advantages of robotics. At the end of the day, I think it's more fun for the surgeon. It's much more exciting to do this rather than do 5 manually instrumented knees in the ASC. It allows for elimination of outliers, dialing in balance, as well as data collection, which we touched on earlier. There has been some data looking at the decreased physical nature of performing these surgeries with a robot. So a robot's here to say, I think we can emphatically say yes. As these have entered fields of medicine, they've never left. And so I think it's up to us to pursue these technologies responsibly. We need data. Has the potential for superior outcomes, although the data's not there yet. And so it's up to us as surgeons to do this for our patients, to pursue it responsibly. So should we take all of our patients to the ASC? We've shown high success rates, low complication rates, low readmission rates. But the answer to this is probably not. Your patients that are on home oxygen, more orthopedically complex, obese, are probably better served in a hospital setting. So in 2023, I do think this is the optimal venue for total joint arthroplasty for most of our patients. But it's not for everyone. Like I said, major cardiopulmonary disease, minimal social support, and you need surgeon commitment and buy-in to the process. So for most of these patients, the ASC, it can be safe, efficient, less costly as a site of care, and lead to high patient satisfaction. Thank you.
Thanks a lot, Keith. So we've heard how to get started, how to transition it to the ASC, and Stefano's going to talk to us about his journey on alignment and robotics. And just a little housekeeping, we're going to have a hard stop at 12 noon to allow everybody to go out, grab their box lunch, come back in here, we'll have a discussion, and then we got to make sure we're done in time to get to the industry sessions that begin at 12:45, correct? Okay, cool.
Jeff and their guys, congratulations on a great program. I think this is the greatest attendance we've had ever at this meeting. This is really exciting. Maybe Jay's responsible for that to some extent. And you're getting old when people start asking you about, talking about your experience about things. So here we go with this thing. It's not been too long. I've had this robot for 2 years, and it's been an interesting and different experience because I was trying to make it do something it wasn't designed to do. So I'm very conflicted with this talk, so I'll be talking about a Stryker robot, and I do consult for them. The other things are not conflicted. So where are we today? I mean, I think we talked about this 20% number, but I was at ISHTA this yesterday. And Faris Sadat showed some data from England, and they didn't look at the back end of the spectrum, the dissatisfaction rate. They looked at the less than satisfied rate and the satisfied rate. And when you get to satisfied, it's in the 30-40% rate. So if we take dissatisfaction as our threshold, and we think of that as the goal to minimize that, and then we start looking at all the risk factors for dissatisfaction, we're basically saying that we're blaming the patients that we're giving up on this procedure. That's my take. And I'm very unapologetic about it. I think dissatisfaction is a terrible threshold. Furthermore, the idea that our patients may be lazy or painstaking or poor compliant or the risk factors are obese or social demographic not following, I think that's also a bit of a cop-out. I think we have a procedure that succeeds from the perspective of survivorship, but we've not met the goal which is set for ourselves to have a nearly forgotten knee. The forgotten knee score by itself is not a particularly good metric. These are very simplistic metrics. We should be looking at kinetics and kinematics, the ability to restore normal function, play tennis, play golf, for everyone, not just those the 20, 30% that you see on everybody's Zoom videos. So we started looking at robotics as a solution, first with the CAS movement. We used navigation. But at that time, we were trying to still hit that one target, which was mechanical alignment. And what we saw was that we narrowed the gaps, but we didn't improve the quality outcome. And what happens when you narrow the variance on either side of the middle, you actually get the same median. But you have fewer outliers. So that's already a benefit, but when you use our standard average outcome, you don't see it. So the reports are, oh, they all look the same. Navigation has the same outcome. Well, actually, I would argue that there are fewer outliers, you just don't see it. But what's happening, and now to assess this, is the robot is actually simply a tool. And when we start thinking about how to use that tool, how to change our thinking and use the data it gives us, you get into that decision support mode, the AI stuff, and I'll show you some data at the very end of this talk that's showing very, very promising results. That allows us to rethink and do things we could not do before. So what is the role of technology in the end? If it just enables us to do the same thing in the same time frame, frankly, it's not a plus. It has to be either a lot faster, a whole lot better, or enable us to do something that we can't otherwise do, make it different. And it has to be easier. Technology has to fall into the background. If it's more complicated, the cost goes up. Your cost of time goes up. Your effort has to be rewarded with a much higher benefit. So I don't necessarily agree. Everybody can read literature differently. I think the literature is very positive for robotics. If you look at the Australian registry, they actually track when a procedure is done robotically. In the United States, 30% of robotic procedures are not marked by AJR, so we can't use our own data very well. But the cumulative percentage rate across the board was significantly better for non-robotic assisted cases. And for this particular robot, for whatever reason, they had even better survivorship. So maybe not all robotic cases are the same. This is the only UK article, but they're also showing, the UKs in particular are showing very, very good results. I won't talk too much more about unis, other than also showing this is half the revision rate for robotically placed unis. The pain scores seem to be about the same. That doesn't seem to make a much difference. There's a claim early on, there was less tissue damage, but probably that's sort of falling out. Impact on surgical training, that's been addressed, so I won't go over it again. The cost effectiveness seems to be tied, depending how you do the math, to your volume, which makes sense because you have to amortize the cost of the robot itself. So the more cases you do, the lower the cost. Across the board, if you look at the cost per case at our institution, it actually went down, much a surprise to our organization, but that was done by the Office of the Controller. And the lower cost over 3 months is basically across the board all statewide databases because of lower readmission rates for some reason. Not entirely clear what that is. But the functional outcomes, I think, across the board have been shown to be good. The learning curve, Haddad and a lot of others have said 20, some have said 60. My personal thing took almost a year to get it down to normal, and I'll tell you why in a minute. But my surgical time usually is a 45-minute tourniquet time, and we're getting up into the hour and then release the tourniquet and have to do it again. And why was that? Oh, and by the way, I did have one complication early on. It was an MCL tear. That video should show that, however, she wound up doing very great. It's a post-traumatic knee that you see there. And I left it in the valgus malalignment it was. And this MCL was very small and just tethered to the bone, and we cut it, unfortunately. But she did great. Accuracy of the robot. This is what its big selling points was, right? So in the uni data, the data is significantly better compared to mechanical, almost 50%, depending how you look at the degrees. And in vivo studies, distal resections, anterior sections, tibial resections within 0.5 millimeter, give or take, are what they wanted. But most importantly, it was within, at least for these authors, it was within alignment, nearly 100% of the time. Now, the question of accuracy didn't really bother people all that much for a very long time. What we did with mechanical alignment, until we came to kinematic alignment, where everything was defined by the resection of the bone. When we did mechanical alignment, we basically cut whatever, and then we do all the balancing through the soft tissues. Whereas kinematic alignment is entirely driven by these bony resections. So as a early proponent of kinematic alignment strategies, and I've been doing kinematics since 2013, it was designed to be used in manual instruments. And actually, in theory, you don't even need x-rays because you're focusing directly on the bone surfaces themselves, resecting as much bone as you're putting back with metal, and that's it. But that means you have to be within a millimeter if your goal is to restore that balance through that bony resection. And the manual instruments were not always accurate. In bigger bones, in smaller bones, hard bone and soft bone. And if you didn't make the cuts, or if you didn't want to follow the patient's anatomy exactly because that was too much for you, taking 2 degrees off the tibia and taking 2 degrees off the femur that matched was nearly impossible. So to me, the promise of perfect cuts really, really got me interested in using the robot. Now again, for mechanical alignment surgeons, the actual resection depth is somewhat irrelevant. And if you talk to any of the reps, the guys using the robots, for the most part, they'll cut the bone, but they don't go and measure it. They just cut it, assuming the robot is exactly delivering what it said it was going to do on the computer. Nader, do you measure your cuts?
I do not.
You measure your cuts? No. Nobody does. So I started cutting, I started measuring my cuts. And sure enough, it wasn't exactly what I expected. So this is the way I set my robot up. I measure, I resect. This is how I start anyway. 8.5 millimeters from the back, 8.5 from distally. Trying to get those condyles to overlay properly, match the slope. And what was happening was I would resect these bone wafers and I'd measure them. It could be up to 2 millimeters off. And so our workflow got to be very, very long because you do your cut, you measure the bone, you look at the resection depth, you reset the computer to recut that bone, to reapproximate it, put it down, and get it all on. It was taking a very long time. The results continued to be very compelling, though. I just got very enamored with the numbers. It was really giving me the kind of feedback that I've been wanting to understand exactly how my knees are doing. There was no question about the gaps. I could match them as I wanted. My lateral flexion gap would be wider. The medial side would be tight throughout the arc of motion. The patella was tracking perfectly. All was good. But it was kind of a that's why that learning curve took so long. And it's hard because when you ask to pick 2 points on distal femur and a posterior condyle, and you really want those to be accurate, it is actually a question mark where you pick those points matters. And as you flex the femur to match your gaps, the thickness of the section will change as well. So now we're getting into the details of it, but the variance was frustrating. To find the right point, especially more complex anatomy, was getting difficult. Now, the platform evolved, though. And when the platform evolved to Mako 2.0 that was released earlier this summer, it started including some of the gap analysis some of the other robotic companies already brought to bear. So now you would be able to estimate the post-resection laxity. So before, the workflow is that I still create my kinematic alignment equal resections. Then I'll remove the osteophytes, and I'll take the knee through a range of motion, testing the laxity. And what happens after that is software calculates exactly what the gaps will be for that patient's knee before I cut it, and allow me to adjust it on the plan before we even start any cuts. So this is from a different company. It's a Corey, but I couldn't find one for my slides deck. I apologize. This is sort of the idea that at different points in the arc of motion, you have different laxities. So then it gives it back to you in this construct. So you're looking, what you're seeing is that for the way I set it up and that particular patient's knee and that particular patient's soft tissue, I was going to have a 4 millimeter lateral gap in extension, a 2.5 millimeter lateral gap on the medial side. And I now have the opportunity to peg the components and move them and get those gaps where I want them to be, which will be along the medial side, a consistent 1 millimeter gap, on the lateral side, a millimeter in extension, and then whatever number it is in inflection. And that changed everything because suddenly I wasn't so concerned about the actual resection thickness because that could determine the laxity intraoperatively before I made the cuts. This, for me, changed me from a pure kinematic, measured resection to far closer to the concept of functional alignment, with the major difference is I actually don't care about mechanical axis because the true FA team wants you to keep it in mechanical axis. The protocol now is much faster. We get this done in less time than the traditional. And as far as I'm concerned, the robotic joint replacement is showing better equivalent results than what we've seen before. The PROM data is lagging, but it's a very blunt instrument. Full three-dimensional control of how implants are moving is possible with intraoperative feedback loops. Now I'm going to show you a couple of interesting things from Mishta yesterday. This is a company that takes a 2D to 3D model. In other words, it takes 2 orthogonal images of the X-ray, no CT scans, recreates a 3-dimensional model, is able to template that model, as you can see here, lateral in 2-dimension, but then also snap the femoral component directly onto that femur. No more finding the right point. You tell it what your goal is, and it'll just put it right on there for you, and then put it into your operative plan. This is a different group. What they did is they did this sequentially and went back and looked and saw what happened to the knee replacements depending on the implant positioning. They then fed it back with an AI loop into the algorithm. So as you do the surgery, it's telling you that the implant as you position will have a specific outcome, and then you can tweak it. And what they found is that the percentage of excellent results went through the roof. So this is a society we founded 3 years ago. It's now going quite well. And it's completely focused on the concept of how do we proceed with personalization of arthroplasty. Our second meeting will be in Bordeaux this year. The next year will be in New York. And it's not just about alignment, but it's entire personalization of care. It's a large international society, and I hope some of you who are interested in the next generation of alignment might consider being part of it. With that, I want to thank you for your attention and walking with me through this journey of adopting and making these robots do things I want to do. Thanks.
Thanks, Stefano. We have a little bit of time before we run off to get our box lunch and come back. Nader, you mentioned we don't have a lot of data, but you think it's promising. So why should the audience consider using robotics?
So I think sort of what I commented on in my talk is that, the current traditional instrumentation that we have is a little bit blunt. You have sort of macro adjustments that you can do to your instrumentation. And that sort of echo what Steph had said, it only goes so far. I think that the robot differentiates itself from navigation and traditional instrumentation because it gives you that micro adjustment and being able to see your balance pre-resection. So I think that it does have an advantage. Clinically, it doesn't bear out yet, but I think as it will in the future. And I think it's a matter of just understanding how we use those tools and how we optimize those tools. So that's why I think it's going to be important in the future.
Nader, are you doing mechanical alignment?
Mechanical, I'll cheat a little bit of varus alignment on my tibia. I'm much more liberal with my external rotation of my femoral component and flexion of the femoral component, but overall shoot external. But I overall shoot for overall mechanical alignment of my implant to be true.
So do you have guardrails? Do you have a point so you can look at the HKA on your planning screen? Where will you not go?
Yeah, I'm not going to go crazy. I mean, 1, 2, 3 degrees is okay. After that, I'm going to restrict myself. Yeah.
Stefano, what about you? I know for a while when you were pure kinematic, you were saying that you would put a tibia at 5 degrees of varus, no problem.
We could have a very long debate, and I'm getting frustrated people are not coming over because the data is so compelling now. But I think we got stuck on the wrong plane. That's the coronal plane is more or less irrelevant. So its balance is fine. Where all the benefit in kinematic alignment comes is the lateral, is having these asymmetric gaps. But people don't understand really. They think of the lateral flexion gap as being wide, as being loose. In flexion, the lateral side is loaded. It takes the highest load of the knee. That gap is not opening. What it is that what you open up when you put a valgus stress on it, you create a gap. What that laxity comes out as is a translation. It allows the femur to roll back the way it's supposed to roll back. And when you keep that flexion gap laterally tight, it doesn't allow it. And when it doesn't allow it, you lose flexion. So one of the problems traditionally forever, everyday paper, if you look at the flexion of a mechanical knee is 115, 116. What you're getting with kinematic is 125, 130. Functional, which is where true functional alignment, you still keep it within 3 degrees. What I'm doing is I'm doing functional, but I'm allowing that gap to open. I'm allowing the mechanical axis to go. But in terms of loads, et cetera, we can go on forever about how it's actually better in native alignment.
So, Keith, how about you? Do you have guardrails you respect?
Yeah, so I do use some guardrails. I do kind of, subscribe to a, kinematic philosophy, but I won't put my tibia in more than about 2.5 degrees of varus, as well as kind of 2.5 degrees on the femur. So I do put some guardrails on it.
Yeah, so it's interesting to see this evolution. About 7 years ago, I think it was the year of the fire, maybe 6 years ago, we canceled the meeting. I was supposed to debate Stefano, and I was going to defend mechanical alignment, and he was going to defend kinematic. And I got to admit, I've kind of gone all in. I jumped into this, and I guess the question is, Stefano, when you look at this version 1, you were looking at your bony cuts, which you're really respecting the morphology. Version 2, you're looking at your cuts, but you're also looking at your soft tissue balance. And so when you think about this, we're talking about 3 things. We're talking about the alignment of the limb, we're talking about the bone morphology and how do we respect that, and then we're talking about the soft tissue balance. So if you agree with that, which one's most important? Is it the alignment, the soft tissue balance, or the bone morphology?
Yeah, I think, look, it's when all we had was metal blocks to do cuts, right? It's all you got. And the rest is feel, experience, do 700 a year, you start becoming your own AI, right? The best way to restore native alignment was with pure kinematic, just distal resections. You had no choice. There was no way to tweak that. I mean, everybody said they would restrict it. I'm like, how are you judging a degree off to change it? I mean, you can't do that. So what happens now with the robot is, like you said, you got the control. But you've also got this new feedback loop. Now you've got the ability to actually measure the tension. We've also done another study looking at stiffness, because there's the third piece is the soft tissue in all this. It turns out if you take a 9mm insert, a 10mm insert, 11mm insert, and a 12mm insert, and you put them in the knee and do what's called a drop test, which measures the swing, how many oscillations the leg will do. From 1 to 2mm above what you resected, the difference is minor. In terms of the stiffness of the whole construct, 1 extra millimeter triples it. So we're very, very sensitive to this idea of balancing, but not the way we thought about in the past. It's actually the tension in that ligament, its ability to withstand any further tension, and it hurts when it goes beyond a certain amount. So we're going to be able to start thinking about, first it was alignment, that's all we had. The next thing is going to be rethinking the alignment to customize the person's specific physiologic knee and balance of the soft tissue. By that you mean the collateral ligaments. But next what's coming is the ability to balance the soft tissues, inclusive of the quadriceps, hamstrings, the whole limbs, soft tissue. So that's where we're going with this, is really truly customizing this to that patient and what they need. And then it's going to be the next generation of customization will be given what their demands are. So it's maybe down the road that for an older person who doesn't do a whole lot, PCL sacrificing might actually be a better need than a CR.
Eric.
So I think we've talked about this a little bit. I think the real promise in these surgical technologies are the data that they provide us, and ultimately trying to marry that with patient-reported outcome measures. Combining that with AI, hopefully coming up with some type of prescriptive algorithm for a 75-year-old female with a BMI of such and such, et cetera. These gaps led to this patient-reported outcome. The problem I find is that we can't merge all of the data that we're getting because of firewalls and HIPAA things. So I wonder if the panel could comment on how they see that evolution of collecting these large data sets, marrying them to prompts, and ultimately helping us develop these algorithms for certain subsets of our patients.
I think that's a great question, Eric. And I think that, to your point, a lot of data is siloed. And a lot of data is not easily translatable between robot systems. But I think all companies are trying to solve the same problem. I think part of it is regulatory, and part of it is sort of, what CMS is requiring now. It'd be great if I had a chalkboard or whiteboard to be able to draw out a system where there's a repository for all the companies to be able to dump into one location and be able to educate the AI. But realistically, what I think is going to happen is that every company is going to have their own data set, and they're correcting their own PROs and develop their own algorithm through their sort of an AI routine to be able to get you to that model. I think it's going to be industry driven to be able to get to that point. But it certainly requires a little bit of a collaboration, both from the surgeon as well as within industry.
Yeah, I think, Eric, that's the holy grail, being able to take that information. I think Keith touched on it. What did you do? Push forward 2 years, 5 years, whatever, and look at good outcomes, and then try and go back and say, okay, in this group we did this, and in this group we did that, and that really is the holy grail. But as you say, it's really not an open platform. It'll be different from company to company.
And it should be different from company to company. Every implant's different. Every robot's abilities are different, and they'll have different data sets. It should be applied separately.
But
Furthermore, you do not need tens of thousands of data points. You need several hundred from each cohort. And then there's all kinds of things you can do with convolutional neural networks to try to identify patterns in the data. And what happens when you do the analysis is we're going to be moving away from this average concept that has, I think, limited our ability to grow in healthcare, which is the randomized controlled trial and the median average, and be able to start looking at distributions within data sets and identify those patients that will respond to different interventions. That is not far away, and all the companies are collecting their data quite well.
But correct me if I'm wrong, but I thought that you can send your sort of robotic data to the company, but the proms is where the firewall is. You can't link that surgical case with a proms, and that's the problem even within one robot system.
The data, so it may not have, you can collect the proms. It has to be in a research environment, right? You can have an IRB for it. And people are doing that as we speak. All the companies are collecting proms data. But you're right that you can't. Now, by the way, the prom data is owned by the patient, right? So they can submit it if they want. You can ask them to do that. You cannot share it without permission, but you can do it. Most of the problem with proms as they're being set up as patients' perception of wellness isn't necessarily going to be as effective in the context of AI as the ability of the robot to help you figure out what kind of biomechanical outcome to get to, right? So there's going to be a jump between the original support systems that will help you achieve a certain functionality, and then we'll have to figure out, once you consistently hit that metric, that perfect patella tracking, that no lift off, that flexion, the balance perfectly aligned, what that does to clinical outcomes. The last thing is that we are focusing on 2 hours of a 3,000-hour journey for patients. There's a big part of recovery that we tend to forget about. It has to do with swelling prevention, DVT prevention, pain management perioperatively. It has a huge impact on patients' perception of their wellness of that knee. And I think we're going to start to learn that that's an important metric to start looking at.
And I think there's some industry, like some companies are trying to couple those with their proprietary apps. So it's an effort, but I think it's a non-coordinated effort.
Yeah, so I think, Mike, last question.
I had more of a technical question about, is there any data to indicate the preoperative measurement with the robot about the kinematics or mid-flexion space correlates with the post-op mid-flexion gap? Because where the robots are going, as you've alluded to, is helping you balance the mid-flexion space, putting the knee through a range of motion, kind of figuring out where to put the thing, and it's based on the assumption that that data before you make your bone cuts is going to be the same as it is after. But you do a whole bunch of other things. You remove the end of the bone, you remove the menisci, you remove the synovium and stuff. And after that, I'm not at all convinced that what you saw in your pre-op assessment correlates with what you get afterwards. And I think we're always going to be stuck with, okay, you figure out the mid-flexion gap or space after you've done everything, and then it's too late to fix it. All you can do is put in a thicker insert if you don't like it. So if you look at the adoption of robots, it's still pretty low, despite, the companies pushing it, you guys all advocate it, a lot of patients want it. But in the Australian registry, the utilization in hips is like 3 or 4%, and knees, I don't know, 10 or 15%. But it's not standard of care yet.
Mike, 50% of strikers' knees are put in with a robot.
Okay, but I'm talking about overall population in registries. So, maybe Stryker pushes it more than others, and they use it that much, particularly in knees. But I think the point I'm making is that there's still something the robot doesn't do. And you're suggesting there's a direct correlation between the kinematic measurement or mid-flexion measurements you get at the beginning of the surgery before you've made your cuts and what you have after. Is there any data to indicate that those two are equivalent? Do you understand my question? All I'm asking about is the data you get when you're putting it through a range of motion and your assumption that when we put the thing in this way, it's going to be the same afterwards. And you kind of don't count the design of the prosthesis, the menisci, the synovium, and the osteophytes, and a bunch of other things that just kind of happen in surgery.
Well, the assumption, this is what you and I will argue forever, I think. I think mid-flexion stability is an artifact of mechanical alignment. It doesn't happen with kinematic alignment. It just doesn't. It doesn't intraoperatively, it doesn't post-op, and it's the one thing I show every resident when they sit in clinic at a month and they see patients come back is take that knee through a range of motion, tell me if there's any mid-flexion stability, and there isn't, there never is. Now, here's one thing I do agree with you on. Intraoperatively dealing with a patient that's coming in with an arthritic knee and all the tissues are quite inflamed and over a year, 2 year, 3 year time frame, those tissues loosen up. And so I do think what happens at 3, 4, 5 years doesn't look exactly the same as they did a few months after surgery. I'm not sure I have a good answer for that one because that's just biology.
Yeah, so Mike, that's a great question. And I think we're just starting on this journey to collect this data. I think anytime an orthopedic meeting starts diving into neural network talk, it's time to take a break. So what I would like to do is have everybody go grab their lunch. We're going to continue this discussion. Hopefully we'll have this just not one way. I'd really like to open this up to the floor because we're all starting a different journey. So let's get lunch, get back here as quick as you can. We'll get started.
Hey, Nader.